2022 series of Georgetown University's Health in the Public Interest program. So the way that we're going to format today is that we're going to have our speaker, Dr. Scialli, speak and then follow with happy students first with their questions, and then our general audience will be able to ask questions as well. So just a little bit of information about the program is that the Masters in Health in the Public Interest, aka HAPPY, is part of the Georgetown University's graduate school. It's a unique interdisciplinary evidence-based training program that prepares students to help solve global healthcare problems and essentially become global health advocates. So students will be able to examine health policy through a lens and takes into account like societal and psychological and cultural factors and how they intersect with the corporate and institutional influences. So today we have Dr. and our own professor, Tony Scialli, and we'll be speaking about the sometimes misleading legacy of thalidomide. And so just a brief information about Dr. Scialli is that he received his Doctor of Medicine degree from Albany Medical College, and he also completed a residency in obstetrics and gynecology at George Washington University Hospital. He took a fellowship in reproductive toxicology with Sergio Fabra, one of the original thalidomide researchers, and Dr. Scialli was professor of obstetrics and gynecology and residency program director at Georgetown University Medical Center for many years. He continues to be actively involved in medical education and teaches on a regular basis at academic medical centers in Washington, D.C. He also founded and was editor-in-chief of the Journal Reproductive Toxicology for 17 years and is a past president of the Teratology Society. So without further ado, Dr. Scialli.
Thank you very much, Tony. So I'm going to talk basically about teratology, which is the study of birth defects. And we'll do a little history of teratology. If a woman had an abnormal baby, then that was interpreted as being a message from the gods or punishment for her or her partner because they had been inbreeding with animals or demons or witches, or the consequence of mental impressions or emotions. One example of that was Joseph Merrick, who was known as the Elephant Man of London. I read a book that was written in 1925 saying that the reason that Joseph Merrick was born with what we now know as Proteus syndrome is that while pregnant, his mother had been frightened by an elephant at the London Zoo. Well, we think of that as being pretty far-fetched, but this person was a physician and was writing this book seriously a little under 100 years ago, when people like to think of themselves as scientific. In fact, for much of modern history, birth defects were believed to be due to genetics. And genetics, as we know it, had first been investigated by Gregor Mendel, who was a priest in what at the time was the Austrian Empire. You can see from the map, the little pointer is on the town where the Right Reverend Mendel worked, which currently is in the Czech Republic, but at the time was in the Austrian Empire. So you'll often read about him as being an Austrian monk. I'm not sure he was a monk, and he certainly wasn't Austrian, at least by modern standards. You can see, in fact, that the town where he grew up was on the border of what is now the Czech Republic and Poland. So Gregor Mendel described in 1865 the transmission between generations of traits, and he used pea plants. So here's a picture of pea plant characteristics that Mendel studied. The top row shows what are called dominant traits. Dominant traits are traits that come out as long as there's one version of the gene coding for them present in the individual. So round seeds, yellow cotyledons, white flowers, a full green pod, and arrangements of the pods on axially on the stem, and tall plants are dominant traits. In the bottom row, you can see the recessive traits. What came to be known as Mendelian genetics, and it's still called Mendelian genetics today, described how if a pea plant had one gene for a round seed and one gene for a wrinkled seed, the resulting seed was round. In order to have a wrinkled seed, the plant had to have two wrinkled genes because the wrinkled gene was recessive, so it could not determine what the plant would look like as long as there was the round seed gene present in the plant. Well, this is all basic second grade genetics. I think most, if not all of us, are familiar with this. And so here's how this is sometimes illustrated by geneticists, showing capital letters for the dominant genes and lowercase levels for the recessive genes, showing that if you had a plant that was dominant for the round seed and the yellow cotyledon, and if that plant were crossed with a plant recessive for those characteristics, the result would be what is called a heterozygote, meaning it had one dominant and one recessive gene. And heterozygotes manifest as the dominant characteristic because the recessive is not enough to determine what the plant looks like. We know this in humans with a number of traits, one of the best known of which is eye color. So there on the left is my mother who had brown eyes, and there on the right is my father who had blue eyes, and below them you can see the baby, that's me with blue eyes. We can figure out what the genes are in these individuals because we know that brown eyes are dominant and blue eyes are recessive. So if my father had blue eyes, he had two little b genes. And so he could manifest the recessive characteristic because he had no dominant genes. We know that I have two blue-eyed genes because I have blue eyes, and if I had one brown-eyed gene, then I would be brown-eyed like my mother. We can figure out from this scheme that my mother must be or must have been a heterozygote because she had brown eyes, but she passed on the blue-eyed gene to me. So this was believed to be the determinant of virtually all physical characteristics in babies, including birth defects. And we now know that something like 20 or 25% of all known birth defects have a genetic basis. All right, so we have to get back to the history of teratology. So we know that in the 16th century, Paré wrote a book, and in fact, I have a copy of the book. And in that book, he explains about supernatural influences causing birth defects. The first modern study in birth defects research was done in 1932 by a fellow named Fred Hale. And Fred Hale described an experiment using pigs and giving pregnant pigs a diet deficient in vitamin A. Now, Fred Hale was not a teratologist. There was no such thing in 1932. Rather, he was a worker at the Texas Department of Agriculture. If you're a farmer in Texas, the success of breeding in your animals is very important. And so Hale said, all right, well, we know that genetics determines birth defects. We also know that the placenta in mammals is very clever. It gives the developing fetus what it needs, and it withholds from the developing fetus whatever might be harmful. But what if we give the pregnant animal a diet deficient in an essential vitamin? What would happen? What's the placenta going to do with deficiency of this vitamin? So he gave a diet deficient in vitamin A, and the resulting piglets were born with a number of malformations, the most prominent of which was absence of development of the eye. And Fred Hale published his findings in, and this is the paper, the title of which is Pigs Born Without Eyeballs. Now, in 2022, don't try publishing a paper with that kind of name, but in the 1930s, that was an okay title to a paper. He not only described these little pigs born without eyeballs, but he also did some experiments with genetics. He mated brothers and sisters who had no eyes. And I know that sounds kind of disgusting, but pigs will do that. And as long as the mother, as long as the sow was given an adequate diet, her offspring were born with normal development. He mated mothers and sons, and as long as the mother was given an adequate diet, the pigs were normal, the little piglets were normal. So he said, this can't be genetics, because if it were genetics, I would have had some abnormal pigs when I mated brother and sister or mothers and sons. This was quite a groundbreaking event because it showed that genetics wasn't the only reason that you could have abnormal embryo development. It led to people saying, well, gosh, let's look at other essential nutrients. And so they tried giving diets selectively deficient in other kinds of nutrients, but it wasn't very easy because, for example, if you want to see what the effect is of deficiency of the amino acid serine, and I'll show you serine in a second, it was not possible to make a diet that was just deficient in serine without being deficient in other amino acids and proteins in general. What was done to get around this was to give analogs of these essential nutrients. Well, what do I mean? There's serine, it's an amino acid. It's used in making peptides or proteins. And because you can't make a diet selectively deficient in serine, what you can do is you could change the molecule by putting on this big clunky azo group. What that does is it allows this molecule to get into serine requiring biochemical events, but it messes them up because this chemical is not good enough to act like serine. So this amino acid analog was given to rats, to pregnant rats, and there were abnormalities in the offspring. That's kind of a proof of concept. The next event in the history of birth defects research was a drug called aminopterin. And this is an event that occurred in humans. So I'm going to show you this, not aminopterin. This is folic acid. And if you did any biochemistry, excuse me, you might remember that folic acid shuttles a methyl group to other molecules, including the precursors of DNA and RNA. So if you give a folic acid analog, maybe you'll mess up those processes. And in fact, the first the first folic acid analog to be synthesized was aminopterin. Aminopterin just has that amino group in place of a methyl group. And so this molecule was good enough to get into folic acid processes and to mess them up. The problem with folic acid analogs, or at least with aminopterin, is that it was difficult to make in pharmaceutically pure quantities, so that it was hard to synthesize. But aminopterin is the first drug to be successfully used in treating childhood leukemia. Childhood leukemia was virtually always fatal, and with aminopterin, the kids didn't die right away, and so it showed some effectiveness for the treatment of cancer. Because of the problem in synthesizing it, another drug was developed called methotrexate with another substitution, which has been used and is still used today for treatment of some cancers. Methotrexate is also used for terminating pregnancies, mostly ectopic pregnancies. That means a pregnancy in the wrong place, like in the fallopian tube, but has also been used as a component of medical abortion therapy. Not very much anymore because it's not all that effective. And what happened in humans is in 1952, by the way, the year I was born, women who were pregnant and had serious diseases that were considered to be a threat to the woman's life were treated with aminopterin in that case. But this also happens with methotrexate. And in fact, these women sometimes terminated their pregnancies. By the way, the diseases, if you read the original paper, the diseases that were considered to be a threat to the woman's life largely consisted of tuberculosis and psychiatric disorders. Well, we like to think today that we can treat pregnant women with tuberculosis and psychiatric diseases with medications that work well and don't hurt anybody too badly. But in 1952, that wasn't the case. Those medications had not been developed. And so these women received aminopterin to terminate the pregnancy. Surgical abortion at that time was not available, had not been developed. And in fact, all of the women who were treated, and there were about a dozen of them, eventually lost the pregnancies, and many of the fetuses were malformed. So this was a human example of the principle that you can take an analog of an essential nutrient and make birth defects with it. Well, in fact, the history of teratology initially involved the use of medications like aminopterin in order to find a treatment for cancer. And so the idea, the rationale was that a pregnant mouse was like a person with cancer in that the fetus, or fetuses in the case of mice, were viewed as parasitic. So what you looked for an anti-cancer drug was a medication that would kill the pregnancy but not kill the mother. And that could be a candidate for an anti-cancer drug. Also, some embryologists use these medications to see if they could figure out mechanisms of embryo development by poisoning specific mechanisms and seeing what happened. In 1960, these three guys got together, and I think they were in Florida. There was no hurricane at the time. Jim Wilson was a laboratory researcher. Clark Fraser was a geneticist from Canada. And Joseph Orkney was a pediatrician in Cincinnati. They got together and founded what was called the Teratology Society. Now the name has changed to the Society for Birth Defects Research, but it's the same society. Now we get to thalidomide. Thalidomide was developed in the 1950s, probably in Germany, but thalidomide was a very special drug. First of all, it was a very good sedative. So it would calm people down, even allow them to sleep if they had trouble in sleeping. And thalidomide was special because sleeping pills in the 1950s and early 1960s had a particular liability, and that was the liability for suicide. Marilyn Monroe overdosed on sleeping pills in 1962, and that made clear to everybody that sleeping pills with a suicide risk were not very good. Well, thalidomide was effective at causing sleep, but it did not cause death in overdose. In fact, there were people who tried to commit suicide with thalidomide. They slept for a long time and woke up alive and annoyed. So thalidomide was viewed as a non-toxic drug that was useful for sedation, as well as other things. There were other conditions for which it was used. Thalidomide was identified in the early 1960s as causing birth defects by these two fellows. So on the left, we have William McBride, who was an obstetrician in New South Wales in Australia, and Vidikun Lenz, who was a pediatrician in Hamburg, Germany. Here, in fact, is McBride's first communication about thalidomide. So this was published in the letters to the editor of The Lancet. Now, The Lancet, as some of you know, is a well-known medical journal that comes out of the United Kingdom. And so publishing a letter to the editor of The Lancet was a good way to get the word out. And he says, congenital anomalies are present in about 1.5% of babies. That rate is a little bit low. It's recognized today that it's more like 2 to 3%. In recent months, I've observed that the incidence of multiple severe abnormalities in babies delivered of women who were given the drug thalidomide during pregnancy as an antiemetic, that means an anti-nausea drug, or as a sedative, to be almost 20%. So McBride published the first description of thalidomide as causing birth defects, but he actually was not the first to bring it to the attention of the world. The first was Lenz, who lived in Hamburg. After thalidomide published his letter to the editor of The Lancet, after McBride published a letter to the editor of The Lancet, Lenz also wrote to the letters to the editor of The Lancet, saying that he read McBride's description, but he actually described the malformations at a medical meeting on November 18th. So he was almost a month ahead of McBride. And of course, part of the issue may have been that it takes a long time to get a letter from New South Wales, Australia to England, where the Lancet was put together. I remember there was no internet in those days, no email. If you wanted to get a letter to the editor to the Lancet, you had to find a piece of paper and write out your letter and put it in an envelope with a stamp, and you dropped it in the mailbox, and then a boat took it thousands of miles to England. So Lenz was first, but probably McBride had been seeing these for a while. And so today they're both given credit for having described the thalidomide embryopathy, as it's sometimes called. The most striking abnormality in babies born after exposure to thalidomide was what's called phocomelia. Phocomelia is a condition where the limbs, which is what melia refers to, are like those of a seal, which is what phoco refers to. So phocomelia means seal-limbed, and here is a child with phocomelia. Now, the idea of it being seal-limbed is because the distal structures, the hands or the feet, were relatively well preserved. These hands are not entirely normal, but they look like hands. They're recognizable as hands. The middle structures, the long bones in the arms and to a lesser extent in the legs, didn't develop at all or were only rudimentary. So the limb was very short with this flipper-like appendage attached to the shoulder girdle for the arms and to the pelvic girdle for the legs. Lenz described phocomelia and its relationship to the cells of thalidomide in Hamburg. So the solid line here is the cells of thalidomide in Hamburg, and this is in kilograms. A kilogram is a little less than half a pound. So you can see that in Hamburg, Germany, in the late 1950s, there were something like 14,000 kilograms of thalidomide sold. And offset by approximately 9 months is the dashed line, which is the incidence of phocomelia in Hamburg, Germany. Not only that, but because it was possible to identify the timing of exposure, it was mapped out which abnormalities occurred with exposure on which days. Now, these are days after conception. And remember, nowadays, most women don't know that they're pregnant until they miss a menstrual period, which occurs something like 14 to 21 days. The menstrual period would be about 14 to 21 days after conception. So these women are rather early in their pregnancy. In the 1950s and early 1960s, women didn't learn that they were pregnant until considerably later, usually until a month or more after conception, because we didn't have those fancy pregnancy tests that you can buy in the drugstore, the supermarket. So we have different malformations, and these are the limb malformations. There's no reason for you to be concerned with the details of what these are, but they're all different malformations involving fingers, thumbs, arms, legs, toes, and so on. In 1966, as a result of the thalidomide episode, the FDA, or what was the precursor to the FDA, decided that we needed to systematically test medications for their ability to cause birth defects prior to marketing. That resulted in a 2-page letter from Edwin Goldenthal that was addressed to all the pharmaceutical manufacturers in the United States or who registered drugs in the United States. So this letter was separately typed. And remember, this is 1966. Well, you have no reason to know this, but no computers, no word processors. Some people at this time had electric typewriters. Most people had manual typewriters. If you don't know what that is, go to the Smithsonian. They have some in there. So some secretarial pool typed up all of these 2-page letters to all of the pharmaceutical manufacturers In this letter, there is an outline of what Dr. Goldenthal felt would be adequate testing. Now, there's kind of a myth out there that thalidomide was never tested in experimental animals. That's not entirely true. It was tested, but not with rigorous attention to pregnancy. In fact, as we'll discuss, in studies that were done in that era with thalidomide, the malformations that occurred were not identified because the techniques for evaluating embryos or fetuses were not developed to the same extent that they are today. So the legacy of thalidomide, in other words, what did thalidomide tell us besides that we need to test pharmaceutical products in pregnant animals? And the first thing thalidomide told us was that embryo toxicity was important if it was selective. What does that mean? Well, here's what's called the dose response curve, where we have dose on the x-axis and some indicator of toxicity on the y-axis. As you raise the dose, you get high enough that you can cause toxicity in anybody or anything. But in the embryo, the dose at which you get toxicity occurs at a dose where the mother is still not affected. In other words, thalidomide was not toxic to adults, pregnant or otherwise, but at dose levels where you had almost no toxicity in the mother, you had severe toxicity in the embryo. Nowadays, this is an important feature of experimental animal testing because if you have a drug that's extremely toxic to adults, let's say a cancer therapy, and you know that if you give it to an adult, that person will lose his or her hair and be nauseated and have no bone marrow cells making blood cells, it doesn't take any genius to figure out that that drug might also be toxic for a developing embryo or fetus. But the selectivity of thalidomide was novel. Prior to thalidomide, the exposures that were known to cause birth defects in human beings were also toxic to adults. For example, rubella virus, German measles virus, and X-ray. So that the use of non-maternally toxic dose levels might or might not give you embryotoxicity. The other legacy of thalidomide that's worth talking about is the idea that the first trimester of pregnancy, roughly the first 13 weeks, is particularly susceptible. And most of us, if not all of us, learned this, that don't take anything in the first trimester because it will cause birth defects, but after that, don't worry about it. This is pure thalidomide, which showed that birth defects could be produced only with exposures between 14 and 56 days after conception. In fact, we know that there are many examples of exposures that produce harm to the developing fetus or embryo with exposures after that. So this timeline shows 3 trimesters in different colors, first, second, and third, and some exposures that cause abnormal embryo fetal development and when their sensitive period is. So for thalidomide, solidly first trimester. For ionizing radiation like X-ray, well, the end of the first trimester and the first half of the second trimester. For warfarin, which is an anticoagulant, or methylmercury, which is an industrial pollutant, or ACE inhibitors. ACE inhibitors are an antihypertensive drug. They cause malformations only after the first trimester. And so it's not enough for us to just avoid exposure in the first trimester. We have to know whether exposure after the first trimester would produce harm. And nowadays, experimental animal testing routinely includes exposures after what in humans would be the first trimester. The other points that thalidomide taught us that aren't always so helpful is that birth defects are special, meaning that if you produce a child with a structural malformation, something you can see, that outcome is more catastrophic than other adverse outcomes might be. Well, that raises the question, what is a birth defect? Is it just a structural malformation that you can see? Or might it include impairment of growth of the fetus or child? How about death of the fetus or the child? How about functional abnormalities, meaning everything looks normal, but something isn't working right? And the one that we're most accustomed to thinking about is the brain. What if you have an exposure that doesn't do anything physically to the child, but the child's brain doesn't work right and the child is cognitively disabled or has some other neurologic disability? These are also important malformations. Here are some examples of exposures that might not cause structural malformations, but might cause considerable toxicity in the embryo or fetus. So smoking, for example, impairs growth, increases miscarriage, may have an effect on cognitive development. This is smoking during pregnancy, not smoking by the baby. And we have other exposures. Marijuana, for example, causes some definite deficits in executive function testing. Executive function is a brain function that involves planning, for example. So the reason you know what to do in your courses, what assignments are due, when you're going to do them, that's all executive functioning. Parvovirus B19, which is a cause of a childhood illness called erythema infectiosum, more commonly known as fifth disease. Parvovirus B19 in a fetus will cause aplasia, meaning nothing developing, in the bone marrow, which gives rise to blood cells. So these fetuses can be stillborn because they don't make blood. Without blood, you can't carry oxygen. Without oxygen, you can't live. So we have trouble with the idea that, let's say, a missing finger is somehow worse than stillbirth. And yet, until rather recently, most testing of pharmaceuticals has concentrated on structural malformations, and there is still a tendency for regulators at FDA and at its European counterpart to value malformations more highly than they value other endpoints. Another legacy of thalidomide is that species differences are important. Species differences mean that if you test in rats, what you get as a result may not reflect what you would get in human beings. This paper, in fact, put evidence forward that thalidomide was as sensitive, or rather that rabbits were as sensitive as rats to thalidomide. It had previously been rumored that rats were resistant to thalidomide effects and rabbits were sensitive. And in fact, this study showed that the difference was in drug handling, meaning thalidomide given orally, given in the stomach, didn't work very well in the rat, but it did in the rabbit. But given intravenously, the species were almost equally sensitive. So we know that species differences are important, but in fact, the difference between species has more to do with the way the drug is handled or other chemical than with inherent differences in embryos. It is, however, true that if you use rats to predict rabbits, you don't always get a correlation. If you use rats to predict mice, you don't always get a correlation. If you use one strain of mouse, it doesn't necessarily even predict what goes on in another strain of mouse. So species differences can be very difficult when you're trying to predict what might happen in human beings. And the final legacy, which I don't think is very helpful, is that the universe of chemicals can be divided into those that cause and those that do not cause birth defects. About 500 years ago, a fellow who had this long name, but is known to his friends as Paracelsus, said that everything is poisonous. There's nothing that's not poisonous. And in fact, the difference between a poison and a remedy is the dose. This was echoed, as I said, almost 500 years later by David Karnofsky. David Karnofsky was an MD. He was a physician. He was an oncologist, which is a physician specializing in cancer treatment. Karnofsky said anything at the right dose, at the right stage of development, given to the right species, will cause abnormal embryo development. I think this is true. Now, Karnofsky wrote this in 1965, shortly after thalidomide, but it's largely ignored by people who want to say this medication causes birth defects, that medication does not. Typically, in medicine, when we're talking to pregnant women, we're talking about medications that are given at a particular dose because they're pharmaceuticals. They only work at particular doses. And so we tend to forget this so-called law. But in fact, anything will produce abnormal embryo development if a high enough dose is given. And finally, I come to therapeutic nihilism. Therapeutic nihilism is a fancy way of saying that women who are pregnant get ignored if they have a disease because the healthcare provider doesn't want to risk producing a birth defect. In fact, this leaves lots of pregnant women with diseases untreated. And sometimes the treatment is better than the untreated disease. For example, women with diabetes, if the diabetes is not adequately controlled, have an increase in malformations, structural malformations, as well as growth problems in their babies. So treatment of diabetes with any medication that's used for diabetes is considered to be important. In fact, what happens is, or what should happen is that the risk-benefit decision, in other words, when does the risk of the drug get outweighed by the benefit? The risk-benefit decision is often made by the regulatory body in the United States, the FDA, or by a legislature. And we're not going to talk about legislatures because I'll say bad things, or the healthcare provider who decides to protect the woman's baby. But in fact, I would like to suggest that the risk-benefit decision is rightfully made by the woman, so that a pregnant woman is not stupid by virtue of being pregnant. She's not uncaring by virtue of being pregnant. She and whatever other people she wants to involve in the decision are capable of doing this risk-benefit calculus. Just as after the child is born, parents are permitted to make risk-benefit decisions for their children. In fact, pregnant women almost always take into consideration whether treatment or avoiding treatment will be in the best interest of their child. And so I would like to suggest that although thalidomide was a very frightening experience, it should not lead us to forget that pregnant women get sick. Sick pregnant women deserve treatment. and that the decision about the treatment should be made by the woman with the assistance of whomever she wants to involve. Thank you very much. All right, Tony, I think the ball's in your court.
Thank you so much for your presentation, Dr. Scialli. We will now open